Hello, I'm Patricia Lavand'homme, working as an anesthesiologist in Brussels, Belgium. So chronic pain in Europe concerns mainly one patient out of 10. So we consider 10% of the patient will develop chronic post-surgical pain. And one patient out of 100, it means around 1 to 3% maximum will have severe chronic post-surgical pain. Is it a problem? Yes, it's not only a problem for the patient, but it's also a socio-economic problem. The awareness about this particular problem, chronic pain after a surgical procedure, has increased with the release of a new definition of chronic post-surgical pain and its inclusion in ICD-11, the International Classification of Disease. And it has been done in collaboration between ISP and the World Health Organization. With this inclusion in ICD-11, we hope to attract the attention about chronic post-surgical pain and also to promote research and collaboration. Today, the management of chronic pain and also severe acute pain relies on the use of what we call multimodal analgesia, meaning we will use a combination of analgesics and anti-hypergesic drugs. However, sometimes it's not enough, and we know that severe acute pain, but also chronic post-surgical pain relies both on an amplification of the pain, but also on patient suffering. So it's important that we have what we call multidisciplinary approach to better manage and control this pain. And by example here, we have PROSPECT. PROSPECT means procedure-specific postoperative pain management. PROSPECT is a good example of the benefit of both multimodal analgesia and multidisciplinary approach. Why? Because in PROSPECT, we are working on the best recommendation to manage pain, not only based on the use of multimodal analgesia, but also in a multidisciplinary approach, because in PROSPECT, we work together, anesthesiologists and surgeons. A transitional pain service have been developed to make a transition between acute postoperative pain, managed usually by the postoperative pain service, and the classic pain clinic. There is effectively a need to take care of the patient developing persistent pain after a surgical procedure as soon as possible to try to manage this pain very early, either proposing a specific infiltration or specific treatment, for example, for neuropathic pain. And the transitional pain service also are slowly changing, at least in Europe. In US and Canada is already the case, but the transitional pain service can take care of patients at high risk to develop persistent and chronic post-surgical pain from the preoperative assessment until the postoperative period. And by example, we know that complicated patient with pre-existing pre-surgical chronic pain and patient with opioid intake and some addiction before the surgical procedure present a high risk to develop long-lasting and even chronic pain after the surgery. Those patients could be taken into account and managed by the transitional pain service before their surgery, in the postoperative period, in collaboration with the acute postoperative pain service, and then follow after hospital discharge by this transitional pain service. And the goal of the transitional pain service is to manage as earlier as possible chronic post-surgical pain, but also to control the postoperative opioid intake and the postoperative intake of also addictive drugs like gabapentinoid. There are several barriers to the widespread establishment of the transitional pain service. I think a very important barrier is the financial aspect. It depends the reimbursement policies, and these reimbursement policies are different from one European country to another. This is the financial aspect. Another aspect is that in this transitional pain service, for this multidisciplinary approach, we need different people. We need not only anesthesiologists and physiotherapists, but also psychologists or perhaps psychiatrists. So we need well-trained people working together. And also we need, by example, in anesthesiology, we need people with an expertise in the different type of infiltration to try to control this persistent and long-lasting pain after surgery. So we need different people with different background. So it means that we need education in the medical doctor. Another important aspect is education of the patient. So they should be aware that persistent pain after surgery can exist and can be managed and treated, and they need to know where to be referred. For that also, we need to educate the general practitioner and all colleague surgeons to asking them to refer the patient as earlier as possible when something is not going well, something is wrong after the surgical procedure. They are the main barrier to the widespread establishment of the transitional pain service.